Hi everyone and welcome to our module on cholinergic antagonist. So in this module we'll discuss everything we need to know about cholinergic antagonists from the classifications of the drugs, examples, the mechanism of action, the indications or uses, the adverse effects, and then the contraindications of drugs under this particular group. Just as we discussed in the previous module, cholinergic agonists are drugs that tend to mimic the action of acetylcholine, and as a result they tend to stimulate cholinergic receptors at different sites in the body. For cholinergic antagonists, these are drugs that tend to oppose the action of acetylcholine, and therefore, how they do this is by blocking cholinergic receptors at different sites of the body. If you remember the introductory class we had in relation to ANS pharmacology, I made mention of the fact that cholinergic receptors are found largely at effector organ sites that are supplied by parasympathetic nervous system. We also find cholinergic receptors particularly at the ganglion, that's whether sympathetic or parasympathetic, and then we find them at the sweat glands. Sweat glands are typically supplied by sympathetic nervous system, but the nerves that are supplying the or innervating the sweat glands will release acetylcholine. Therefore, cholinergic receptors are found on the sweat glands. The job of the cholinergic antagonist at this different site is to block the receptors, and as a result, we tend to refer to cholinergic antagonists as cholinolytic agents because of their breakdown of the parasympathetic nervous system or at the site in which they are opposing cholinergic receptors. How do we classify cholinolytic agents or cholinergic antagonists? We classify them based on the type of receptors that they are blocking. So remember that we have two types of cholinergic receptors, muscarinic and nicotinic receptors. We have drugs that are classified as either anti-muscarinic, meaning that they are working to antagonize muscarinic receptors exclusively. And we have drugs that are classified as anti-nicotinic. These are drugs that work on nicotinic receptors exclusively. If you remember, in terms of the distribution of these receptors, muscarinic receptors are found at the effector organs, at visceral organs, right? Whereas the nicotinic receptors are going to be found at two sites, the ganglion being one and the skeletal muscle. Right, but remember that skeletal muscles are part of the somatic nervous system, so we don't really talk so much about them. We'll focus our attention on the ganglions here. Each of these different classifications are further subclassified. Antimuscarinic agents are subclassified as natural drugs and synthetic drugs, and we also have a subclassification of semi-synthetic drugs. We'll talk about that. For the anti-nicotinic agents, depending on whether they are working on NN receptors or NM receptors, they are further classified as either ganglion blockers, those are the ones that are working on NN receptors, and neuromuscular junction blockers, those are the ones that work on NM receptors. So it's just a picture that talks about the breakdown of the cholinergic antagonist hormone with just a few differences. Remember that we can classify these drugs as either muscarinic or nicotinic antagonist. The difference between this classification and the previous one is that the muscarinic antagonist in this case is classified as either selective drugs or non-selective drugs. Most of the muscarinic antagonists that we have are non-selective, as we will see in the next couple of slides when we talk about the examples. Only a few examples of muscarinic antagonists are selective. Usually we have M1 selective and M2 selective drugs. So let's talk about the different examples under the classifications of cholinergic antagonists. I will be using the initial classification, the classification of antimuscarinic into natural drugs, synthetic drugs, and semi-synthetic drugs. Starting with the natural drug, we have two major natural drugs that we refer to as antimuscarinic agents, and this is by virtue of where they are gotten from. For a drug to be called natural, these drugs must be derived directly from either a plant source or an animal source. In the case of the two natural antimuscarinic agents we know of, these drugs include atropine and scopolamine. Scopolamine is also called iocin. So in case you see iocin or scopolamine, they mean the same thing. These drugs are gotten naturally from plants. Atropine is gotten from a plant called the Tropa belladonna, and as a result, we tend to classify it alongside scopolamine as natural agents. For the semi-synthetic drugs, the drugs that are gotten partly from the natural plants or natural sources and partly from synthetic sources. So they tend to modify the naturally gotten drug and in the lab, and that's why we call it semi-synthetic. Examples of these drugs include drugs like homotropium, atropine methyl nitrate, and iosine butyl bromide. You might see more examples in your slide, but pay attention to these first three that I've given. For the synthetic agents, now the synthetic agents can be further grouped into selective and non-selective. Like I said, majority of our anti-muscarinic drugs are non-selective. Synthetic drugs include drugs like tiotropium and ipratropium. These drugs, we'll talk about them when we get to the module on anti-asthmatics. Tropicamide, tolterodone, sulfifenazine, benztropine, oxybutynin, darafenazine, and propafeniline are all examples of non-selective synthetic acting drugs. You might have a little bit of confusion in your slide compared to what is my slide. Sometimes we tend to classify tiotropium and ipratropium as part of the semi-synthetic drugs. So whatever is given in your slide, please do follow. Other examples of non-selective synthetic antimuscarinic agents include drugs like triethylphenyl, cyclopentolate, dicyclomine, and glycopyrrolate, amongst other examples. For the selective synthetic agents, like I said, we have very few selective synthetic antimuscarinic agents. And typically, these drugs are either M1 selective or M2 selective. Drugs like telenzepine, pirenzepine, and triptamine are all examples of selective synthetic antimuscarinic drugs. Moving on to the examples under the anti-nicotinic agent. Remember, anti-nicotinic agents are further classified as either ganglionic blockers or neuromuscular junction blockers. This is by virtue of where they are working specifically. For the ganglionic blockers, they are working at the NN receptors at the ganglion. For the muscarinic junction blockers, they are working specifically at the NM receptors in the skeletal muscles. Though we don't really talk so much about the NNG blockers, we'll focus on them. We'll talk a bit about them in this module, but we'll focus on them largely at the module on antispasmodics, the module on neuropharmacology. But for now, it's important for you to note the subdivisions of each of these different antinicotinic classes. For the ganglionic blockers, they are further subdivided into depolarizing blockers and non-depolarizing blockers. I'll talk about the differences between each of them when we talk about mechanism of action. Also, for the neuromuscular junction blockers, the NMG blockers are also classified as either depolarizing blockers or non-depolarizing blockers. So examples of anti-nicotinic drugs, starting with the ganglion blockers. Remember, ganglionic blockers are further divided into depolarizing or non-depolarizing. It's important to note that depolarizing ganglionic blockers are also called non-competitive blockers. So please remember that this, in case they switch the name, so sometimes they can use depolarizing or non-competitive. They mean the same thing. Examples under this are drugs that we are very familiar with under the cholinergic agonist list. The two drugs that are classified as ganglionic depolarizing or non-competitive blockers are nicotine and organophosphate. But you should know that these drugs are only classified as ganglionic blockers at high dose. So at typical normal dose of nicotine or organophosphates, they would be classified under the group of cholinergic agonists and not antagonists. For the ganglionic blockers that are classified as non-depolarizing or competitive drugs, these include drugs like hexametonium, mecamilamine, trimetaphan, pentolinium, and pemfidine, amongst others. These are the important ones you really need to remember for your MCQs. Moving on to the neuromuscular junction blockers, they are also further classified as depolarizing and non-depolarizing. Depolarizing drugs are also called non-competitive, and the two common examples you need to remember is succinylcholine, also called susamectonium, and decametonium. For the non-depolarizing or competitive neuromuscular junction blockers, we have them further sub-classified as either long-acting drugs, short-acting drugs, and intermediate-acting drugs. And it's important to note them. So for the long-acting drugs, we have drugs like tubocurarine, pancuronium, doxacuronium, and pipecuronium. If you pay attention, you notice that there's a bit of similarities in terms of the suffixes of some of those drugs. So, for example, pancuronium and pipecuronium have the coronium as the suffix ending them, and this is just for you to remember your drugs. And doxychlorium and curarine have a similar suffix. We'll talk about other drugs that sound similar to curarine or curonium or curium later on. This is not just something to note in terms of learning the examples, but also there tend to be similarities in each of these drugs. So pancuronium, the coroniums, pancuronium, pipecuronium, tubocurarine, and doxychlorium tend to have um, similar properties that differ from each other. So tubocurarine and doxychloroquine, for example, are drugs that tend to be involved in release of histamine. They're histamine releasers. And pancuronium and pipecuronium, drugs that end with coronium, tend to be um, regarded as vagolytic agents. So it's important to remember this, that though they have similar, the drugs that have similar suffixes tend to have similar properties, and they differ from other drugs that have a different suffix ending them. For the intermediate acting drugs include drugs like vecuronium, urocuronium. You can see the suffixes coronium again. Remember that these drugs ending with coronium tend to be vagolytic in action. And then we have cis atracurium and atracurium. You can see the curium present there also there to mirror drugs that are histamine releasers. These drugs are also similar in their um, chemistry. That is why we give them um, we give them similar suffixes. So the coroniums, for example, are regarded as steroidal agents, steroidal compounds, whereas the curium, on the other hand, are regarded as benzyl isoquinolines. So, so just to quickly recap on that again, for neuromuscular junction blockers, we have them further classified as depolarizing and non-depolarizing. For the non-depolarizing drugs, we sub-classify them as long-acting, intermediate-acting, and short-acting. And each of those drugs can further even be classified based on their chemistry or based on their extra properties. How we tend to remember them is that drugs that end with coronium are regarded as steroidal compounds and they tend to be vagolytic in their property. And drugs that are ending with a curium, including tubocurarine, are drugs that are regarded as benzyl isoquinoline in their chemistry and their histamine releasers in their properties. The last drug I didn't mention there are the short-acting drugs, and the major example of the short-acting drugs is the mivacurium. Let's talk about the mechanism of action of our anti-muscarinic and anti-nicotinic agents. Starting with the anti-muscarinic agents, these drugs tend to bind and block to muscarinic cholinergic receptors at the different sites, particularly at the effector organs supplied by the parasympathetic nervous system. And in doing so, they will block this muscarinic agent and prevent the natural ligand, which is acetylcholine, from acting on these receptors. Remember that for a drug to be an antagonist, antagonists don't necessarily stimulate or um, com- um, cause conformational changes on the receptors. What antagonists tend to do is that they tend to sit on the receptor site and then they prevent the natural ligand from acting those receptor sites. And that's practically how antimuscarinic tend to do. They sit on the receptor site on muscarinic receptors at different sites and then they prevent endogenous acetylcholine from acting on those receptors. There is a picture of how the anti-muscarinic agents tend to work. You can see anti-muscarinic agents represented here by this lock. What it does is that it just sits on the muscarinic receptors that you can see here, and in doing so, it kind of padlocks it and prevents acetylcholine from doing anything on this receptor. And that's how we say that anti-muscarinic receptors tend, anti-muscarinic drugs tend to block different receptors. For the anti-nicotinic agents, it has similar action but with a bit of differences. Remember that anti-muscarinic drugs tend to either bind on NM or NN receptors. For the drugs working on NM receptors, they tend to act at the neuromuscular junction. For the drugs working at NN receptors, they tend to work at the ganglion. For the ganglionic blockers or the neuromuscular junction blockers, if you recall, these drugs can either be classified as non-depolarizing or depolarizing. And these drugs tend to have similar activity, either we're talking about the ganglionic blockers or the neuromuscular junction blockers. Starting with the non-depolarizing drugs. Non-depolarizing drugs works exactly the same way in which the anti-muscarinic drugs are going to be working. So non-depolarizing drugs tend to bind on the nicotinic receptors, whether NN or NM, and they just sit on the receptors and then they prevent the endogenous ligand from acting on those receptors. So they prevent acetylcholine from working on the NN or NM receptors at those sites. Depolarizing drugs tend to have a different mechanism of action. For depolarizing drugs, whether we're talking about ganglionic depolarizing drugs or neuromuscular junction depolarizing drugs, how these drugs tend to work is that they act on the receptors and they overstimulate the receptors. The key emphasis on the word overstimulate. Because they are overstimulating the nicotinic receptors at these sites, they tend to lead to desensitization and inactivation of the receptors as a result. And the inactivation of the receptors will lead to the receptors becoming blocked at the end of the day. If you remember our discussion on the drug receptor regulation, remember that continuous or excessive exposure of a drug to a receptor will lead to desensitization and eventually inactivation. And that is practically how the depolarizing agents tend to work. They overstimulate the receptors get tired of them, the receptors become desensitized, and as a result, they become inactivated. So this is just to illustrate the fact that anti-nicotinic agents would either act on the nicotinic receptors at the ganglion or nicotinic receptors at the skeletal muscles. In this picture, what is being depicted for us here is the ganglion. As you can see, this is the prevertebral ganglia, and this is going to be one of the sites for the anti-nicotinic drugs, particularly on the NN receptors. In this picture, this is to illustrate the fact that our anti-nicotinic agents would also be working at the muscle site, skeletal muscle specifically. And these drugs tend to be referred to as the neuromuscular blockers or neuromuscular junction blockers. They particularly work on NN and M receptors found at this site. Now, differences between the non-depolarizing blockers and depolarizing blockers, either we're talking about the NMG blockers or ganglionic blockers, is depicted in the image above. As you would see, acetylcholine being the natural ligand acts on the nicotinic receptors, and nicotinic receptors being an ionotropic receptors. Once the acetylcholine binds to these receptors, it leads to the opening of sodium-gated channels, ligand-gated sodium channels, and then sodium influx would occur, leading to depolarization. That's what occurs when there's natural ligand working at these different sites. If a non-depolarizing blocker, whether ganglionic blocker or NMG blocker, is used, this non-depolarizing blocker, as you would see, will just go to the receptor site and block the receptor site. You can see this is the non-depolarizing blocker blocking the receptor site. And in doing so, to prevent acetylcholine from acting at that site, the inactivity of acetylcholine at the site will lead to the effects that we see when the non-depolarizing blockers are acting. The depolarizing blockers tend to have a different action. Depolarizing blockers would act on the receptor site and overstimulate the receptors. And this overstimulation would eventually lead to a blockade as a result, because once a receptor is overstimulated, it becomes desensitized, and desensitization will lead to inactivation. And that's what you can see. You can see that though the polarizing blocker is stimulating the receptor, as you can see, sodium channels are not entering into it because the receptors have become inactivated. So to confirm the activity of a depolarizing blocker, usually when we give a depolarizing blocker, an NMG depolarizing blocker to an individual, we tend to see two phases of action. Remember that the NMG blockers are going to be acting on the skeletal muscle. So we'll be looking out for changes in the skeletal muscle. And what we do notice is that there are two phases of action that tend to occur after giving a depolarizing blocker. These phases are called phase 1, phase 2. The phase 1 is also called depolarizing phase. Phase 2 is also called desensitizing phase. Remember that when we're talking about the mechanism of action of the depolarizing agents, the first thing they will do is that they will overstimulate the receptors. If they are overstimulating the receptors and the receptor is an NM receptors on the skeletal muscle, the first thing we see is that we tend to see contraction of those muscles, what we call fasciculation of those muscles. So there's fasciculation, the muscles will start to beat because they are overstimulated. And that's what we see at the depolarizing phase. After a while, once the receptors start to become desensitized and become inactivated, the effect changes from fasciculation to flaccid paralysis. And that's what we see at phase 2, what we call the desensitizing phase, in which the receptors become desensitized and inactivated, and as a result, the skeletal muscles become paralyzed automatically. What are the uses of our cholinergic antagonists, starting with the antimuscarinic agents. Antimuscarinic drugs are used for numerous reasons, one of which is a condition called overactive bladder syndrome or irritable bowel syndrome, and as well diarrhea. So, irritable bowel syndrome and diarrhea kind of have similar symptoms. Overactive bladder syndrome is a scenario where there's an excessive urination occurring or excessive maturation occurring, and our antimuscarinic agent will block muscarinic receptors and reduce maturation from there. Irritable bowel syndrome and diarrhea also tend to have similar symptoms in the sense that there's going to be increased defecation, and the job of the antimuscarinic agent is to bind on the muscarinic drugs, the muscarinic receptors, and block these receptors, thereby reducing peristaltic movement in the GIT. Other uses of antimuscarinic agents include motion sickness. Particularly motion sickness, we tend to prefer the use of the drug scopolamine. Scopolamine and iosine is the drug of choice for motion sickness. Please do remember this. Peptic ulcer could also be treated with antimuscarinic agents. We could either use one of the selective antimuscarinic drugs, like the M1 selective drugs, because we do find M1 receptors at the stomach in the gastric tissue. So one of the ways we can treat peptic ulcer is by giving an M1 selective drugs like telencepine or pyrenzepine. We can treat uveitis using antimuscarinic agents, and we can also treat chronic obstructive pulmonary disease and asthma with antimuscarinic agents like tiotropium and ipratropium. Other use of antimuscarinic agents is in the condition of extrapyramidal symptoms when we are giving a patient antipsychotic agents, or if a patient has Parkinson's disease. One of the drugs we could use to treat the extrapyramidal symptoms seen in antipsychotic use would be drugs like benztropine. Benztropine is a common example, or triaxylphenidil could also be an example. We could use atropine in treating sinus bradycardia. We could also use atropine in treating as drugs that we use as what we call mydriatics or cycloplegics. And we could also use atropine in treating anticholinesterase poison. Remember that we talked about this in the previous model under cholinergic agonist. That once we are using a cholinergic agonist and there has been an overdose of this cholinergic agonist, like an organophosphate, one of the antidote to treat that is by giving atropine together with another drug called pyridoxine. So atropine is used as the antidote to anticholinesterase poison. And it's a child that has motion sickness. This is one condition that I'm very familiar with. Moving out or traveling long distance usually tends to make me noxious, and as a result, so one of the drugs I tend to use to prevent this is butyropamide, hyoscine butyropamide, which is scopolamine. So this would help me prevent those symptoms, and as a result, help in preventing motion sickness from occurring. So this picture depicts for us the use of ipratropium and tiotropium as a remedy for asthma or COPD. So you see, use of the inhalers that contain each of these substances could lead to bronchodilation of the lungs, and as a result, there's more air flow and air loss. We prefer to use ipratropium and tiotropium for more of COPD compared to asthma, and that's why we're seeing it in this particular image. We could also use our cholinergic antagonist like atropine as a mydriatic. What mydriatics tend to do is that they tend to dilate the pupils. We use mydriatics in ophthalmological investigations. If someone is going to be investigating changes within the eye and we want to see through the eye very well, we would dilate, first of all, need to dilate the pupil so we can go in and look at what's occurring within the eye. I had this an experience with this once when I was young, when I was supposed to do a glaucoma test, and they were viewing the different part of my eye just to be sure that my optic nerve is not being damaged. They had to give me my triatic, most likely atropine, that dilated my eye, and then they were able to view different parts of the optic nerve from there. Indications for anti-nicotinic drugs are very few. These are drugs that we will talk about in a separate module when we get to neuropharmacology. The two indications for anti-nicotinic agents are as a muscle relaxant when performing surgeries, and as an antitussive. We'll talk about antitussives in the respiratory pharmacology module. Here's an image of someone going into surgery, aside anesthetic agents that we give to the person to put them to sleep, one of the drugs that we must give as well is a muscle relaxant. We don't want this scenario where we're cutting through someone's muscles. They are having muscle reflexes. Um, we want to avoid scenarios where the patient will be slapping or kicking the surgeon while the surgeon is operating. So as a result, we give muscle relaxants to relax the muscle to numb the reflexes so that surgeries could easily be performed. And one of the common examples of a muscle relaxant is the NMJ blocker we talked about, the neuromuscular junction blocker, whether depolarizing or non-depolarizing. The adverse effect of cholinergic antagonists include things like hyperthermia, tachycardia, xerostomia. Xerostomia is dry mouth. Hyperthermia is an increase in temperature. There's a flushed skin seen, hallucination tends to occur, confusion as well, constipation, urinary retention, mydriasis, and then cyclopedia, which is loss of accommodation. These are all side effects of cholinergic antagonist. And there's a unique way to remember each of the different adverse effects of cholinergic antagonists. I tend to use this song to teach students regarding it. So it goes like this: hot as Hades. Hot as Hades tend to mirror hypothermia or fever. Fast as a hair, that is tachycardia. Dry as a bone, that is xerostomia or diaphoresis. That's reduced sweating and reduced salivary secretion. Red as a beet is flushed skin. Mad as hatter is delirium or confusion or hallucination. Full as a tick involves urinary retention and constipation. Blind as a bat involves mydriasis and cyclopedia. So the contraindications for cholinergic antagonists are conditions in which we should never prescribe cholinergic antagonist for. So things like tachyarrhythmia. Remember that we give cholinergic antagonist for people that have sinus bradyarrhythmia. So people that are tachyarrhythmic are going to have their conditions worsened if we give them cholinergic antagonist. Heart failure could also be a contraindication, myocardial infarction, hyperthyroidism. Obstructive gastropathy and obstructive uropathy are both surgical cases, so there's no need to give them to give drugs for these particular conditions. Glaucoma is also a contraindication. We use cholinergic agonists to treat glaucoma. Giving a cholinergic antagonist will worsen a person's case. Myasthenia gravis is also a contraindication. Remember that we are giving drugs like neostigmine and physiostigmine to treat myasthenia gravis, and these drugs are cholinergic agonists. So blocking the cholinergic receptors will further worsen the person's case because the person already has very few cholinergic receptors in myasthenia gravis. Paralytic ileus and hiatal hernias are both contraindications because of the issues surrounding the GIT in these two conditions. And that concludes our model on cholinergic antagonist.